this morning and sharing the podium with Giovanni and the other speakers. I obviously thanks a lot, Sweden Martina, for involving me in this meeting, as well as SIPA and CDP. Obviously now we are switching into another topic, is more related to the heart tissue vision, and I want to make a sort of journey, even if the time is relatively short, in these 40 minutes, talking about the fact that when we are in an initial situation that we have all the soft tissue and the hard tissue in the correct position, and basically we want to preserve the situation. We have a lot of information nowadays to maintain what is present, to improve sometimes an initial situation, but in the majority of the case, we have all the bone structure almost there. So in many times, what we are going to do is just to preserve what is present, to preserve the soft tissue and the hard tissue architecture, sometimes meaning not exactly maintaining the same shape, but try clinically to have the same appearance. And in this way, to obtain a nice result from hard tissue and soft tissue point of view, and this is the goal of the treatment every time. And we like to see a soft tissue around our implants that are very close to a natural appearance of the natural dentition, and what we want to see is also a stable bone around our implants. And this is a very important point. And what I would like to also to share is the fact that using an intramucosal implant, we have the chance to reduce the stress in the very critical area, which is the deepest area of the soft tissue in close contact to the bone. And by doing this, we have the chance really to don't touch and to preserve the sealing in the deeper part of our pocket. And as I said, we have a lot of opportunities when the bone is there, when the majority of the bone is there, because we can prepare the site, we can insert implants in the correct three-dimensional position, we can preserve the volume of the bone. I wouldn't say the bone itself, but the volume occupied by the bone inside in this alveolar structure, and obviously increasing the soft tissue thickness to maintain the aspect of the architecture during the healing and during the maturation phase. And this is an important point if we want to achieve a natural shape of our crown supported by the implant, and to see also a very stable contour of the soft tissue and a nice seal that lets the bone to improve the density very close to the neck of the implant. And in many cases, luckily, we can compensate some defects that appears as a bone defect, but just working by soft tissue, meaning that, and this is we learn a lot with what has been described by Giovanni, and improving the quality and the height of the tissue, even if we have a very little amount of bone just to place the implant, but we don't need any time that we see a missing volume, think about the bone. In the majority of the case, we have to control if the deficiency is involving the supracrestal structure, meaning what is over the bone, or what is in the bone compartment, because the approach is completely different, and we may achieve very wonderful volume situation like this without touching the bone at all. And in many cases, we can do this. Obviously, we have maybe to perform twice a connective tissue graft, but we can bring back the aesthetic, bring back the volume of the soft tissue in a very nice way. And every time we do this, we like to have the volume of the tissue in the right position, like in this, and finishing a case with a nice tissue, a nice good proportion. And to see radiographically a very nice amount of bone in the right position with the right amount of soft tissue around these implants. But this is possible, and luckily in the majority of the case is possible, when we have the bone in the correct position. But the starting point of this case was this, meaning that to take care about the supracrescent structure, we have to take care first, if the necessity, about the bone. Because we can work a lot with the soft tissue, we can improve the quality, the quantity, the horizontal thickness, preparing the tissue to grow also in the vertical direction, but we must have the bone under it. And when we are starting a situation like this, and we want to end up with a natural appearance, we are missing 90% of the bone needed to place the implants in that position. And to do this, we must know the rules for rebuild up the bone. And we must know that we have to follow protocols that are predictable, meaning that they are going to work in all patients. Obviously 100% doesn't exist in terms of success, but we must try to be very close to that 100%. So the predictability of the process is very, very important, because in many cases like this, we have no other chances. Or we build up the bone, or we are not going to place implants. We are not going to achieve any type of nice shape of the soft tissue. So we must go a step back, thinking later on the soft tissue management, and firstly to build up the bone. And these type of patients with a lot of deficiency are growing a lot, because in the many, many cases, here we have implant failure after perimplantitis. And when you have a perimplantitis around an implant, and you try to keep the implants years, even if the bone is still going down, at the end, you're going to miss at least 8, 7, 10 millimeters of bone. And to go back, then you have to build up, to reshape completely the bone architecture. And must be bone, otherwise your implant will be placed in something that maybe radiologically seems to be bone, but is not behaving as a bone tissue. And then the stability of the new implant will be quite questionable. And if I'm looking on the literature, it's a very critical point, meaning that we cannot speak about predictable approach if I have such a complication rate. We try to do something if I have this type of complications rate. And at the end of the day, the main point, the expectation of the patient for sure is aesthetic, as Giovanni said, but it's for sure to go through a treatment which is predictable. Because it's very difficult for a patient, but I put myself on this side, to go through a surgery or multiple surgeries knowing that I have 20% of risk of complication, which is very high. It's incredibly high. So the predictability is a crucial point. And to improve the predictability, we must know the rules, the biological rules to build up the bone. And you know that I'm now in the regeneration field since my postgraduate program, so it's more than 15 years that I'm working on this. And in more than 15 years, I had never a patient coming to me with a deficiency and asking, please do a courier approach on myself or do a PTFE vertical augmentation. They are just coming with a problem, and they don't, I would say, they don't care about what is the approach we are going to develop. What they want is to start in that situation and end up in a nice situation. And possibly to have this rebuilt architecture that is stable, clinically stable, during the years. Because this is the point. So, in the literature, obviously, we have a lot of approaches that we can use, a lot of materials, a lot of flap designs, and many, many things. But at the end of the day, we must remember that if we are able to build up the bone here, it's just because the process is not related to the surgery. Meaning that you can do a PTFE approach, you can do a Curie technique, you can use a titanium mesh, but if the bone is going to be formed here, it's going to be an intramembranous ossification, because the biology knows just one way to do that. And we must know this. So the result, the bone formation, maybe it's hard to hear, but it's not depending on the technique. The technique is just creating a scenario where the biology is going to run. If the scenario is a good scenario, biologically speaking, then the process will run maybe faster, will be more predictable, but the way the bone is going to be formed, it's an intramembranous ossification. And the basic rules is the presence of a blood clot that is going to be transformed into a provisional matrix, that is going to be transformed then in woven bone. But the jump from stage 2 to stage 3 of the healing is depending on physical and chemical environment. And then, where the woven bone has been formed, we may have lamellar bone, which is the mature bone. These are the steps, and these are the steps independently from the surgical approach or the bone augmentation approach. So what is needed to obtain the good result, to be predictable, to have from the provisional matrix to the woven bone formation? We must have three elements coexisting simultaneously on the site, which is vascularization, must be abundant, we must have inductive factors, and we must have mechanical factors. These are three elements which are fundamental. And the vascularization must be run fast and furious, because the bone formation is depending on the quantity of vessels forming in that area and then the speed of the blood vessels formation. So when we are going to look to a defect, to understand what I need on a deficiency to build up the bone, to build up the correct scenario, I must ask myself two questions. How many walls I have in that defect, and how many, or which is the distance between the walls. These are the two elements affecting the biological process. Why? Because we know from the literature, and we have a lot of papers describing this. This is a GBR, for example, study, telling us that the bone is starting forming from the bone walls of the deficiency. So if you have three bone walls, three sources of new bone are going to develop in that area. And the distance has a big impact, and we know, for example, in the sinus, from these PhD studies, that if I have the buccal and palatal wall very close to each other, the bone will form faster because there is less way to be run in the defect. So these two elements are giving us a lot of information regarding the predictability of the process in an area. But just remember that jumping from 10 millimeters to 15 millimeters, I have a decrease in bone formation of 30%. Of 3 times less. So when I'm looking to a deficiency on the crest, and we are talking about 1 missing tooth cap, or 2 or 3 missing tooth cap, even if the vertical dimension is the same, we have 3 completely different scenarios, with 3 completely different predictability in bone formation. So we must know that, and we know that the distance has an impact even in the dynamic of bone formation after a tooth extraction. So the distance between the source of bone is impacting dramatically in the overall process. So number of walls, distance from walls, and obviously less walls and more distance has an impact on the mechanical protection, meaning that I have to take care about the mechanical protection by deciding how I want to build up the bone in that area. So if I'm looking at deficiency like this, I have a big distance from the walls, I have a relative narrow base, so I have a mechanical problem, and not just the surface that are very narrow that are going to participate to the side. And from my point of view, this is a very critical scenario, or a very critical defect. And if I'm going to apply a membrane here, for example, a PTFE membrane, I'm going to exclude the vascular support from the soft tissue, which are going to represent the 2 major walls in this defect. And we know from literature, for example, the last paper by Istvanuba was published 1 year ago, that there is a decrease on predictability of bone formation if you are increasing the vertical dimension of the augmentation. Under 5 millimeters, you have a very high predictability, predictability. From 5 to 8, the predictability is going to decrease, and over 8 is going to decrease more than 10%, because you are excluding a part of the vascularization of the vascular support in the area. So my point of view, but this is really personal point of view, is that all the deficiency where I can work simultaneous with implant placement and there are less than 5 millimeters, I work with PTFE membrane because they are very, very predictable in terms of bone formation. If I have major deficiency, then I prefer to work meaning more than 5. I'm going to switch the implant placement from the bone augmentation, and I use the Curies approach that allow me to work without the application of any membrane. So the vascular support will come from the hard tissue and soft tissue, both sides. Now, why using autogenous bone? Because the autogenous bone is the only material that when it's present is going to improve the speed of bone formation. It means that it's not going to change the biology. The steps of the intramembranous ossification are going to be respected perfectly, but the speed of bone formation allowed us to cover more distances or longer distances compared just to the coagulum or any other material. And we know this from randomized clinical trials, for example, in the sinus, where we have much more bone formation with autogenous bone compared to the other material. And we know that improving the quantity of autogenous bone is improving the quality of the tissue that we are going to build it up. So thinking that 90% of our implants is going to be seated in that area, I want to have the best quality tissue regenerated as I can. And obviously we have to make a choice. We have to decide if I want to use a block or if I want to use a particulated material, because this is going to have an impact on the vascularization. Because here we have like a stone in the water, meaning that the vascular support cannot grow fast inside. We grow just around the block. Here I have the capability for the blood vessels to grow very fast inside the graft because I have spaces between the particles. But what I'm missing there is the mechanical stability of the environment that I have here. So I have advantages and disadvantages on both approaches, and what we can do is combine, here is coming the Curies approach, combine the use of a block, a solid block, which is going to be divided into 2 lamina and scrape it, meaning that we are going to have, from one solid block, we are going to have 2 lamina, keeping the mechanical environment stable and the particulated material that allows a fast vascularization. So this is the concept behind the Curies approach. And we know also from the literature that if I'm going to apply a membrane over it, I'm going just to reduce the vascularization speed or the chances to have a vascularization from the soft tissue, which is not a problem. It's just helping us to have more vessels in that area. And more vessels means more bone formation in the same time frame. And this is what we want to have, meaning that we have the deficiency, in this case is an 8 millimeter deficiency for 2 centimeter mesiodistally. It means that we have a huge deficiency, and this is 4 months later, meaning we have a very nice results with no application of any type of membrane. But we must understand that the autogenous bone is not for every type of deficiency, because autogenous bone will follow in the time of regeneration, and particularly in the physiological renewal, is going to follow anatomical envelopes, meaning genetics, and functional, so related to the muscle activity in that area. So autogenous bone is fantastic if I want to have new vital bone, but it's not necessarily the best material. In many cases, it's the worst material if I just want to have new volume. If I want to have new volume, I must work with something that the body, in the physiologic renewal of the tissue, is not going to take away or to reduce. Connective tissue is a very nice example how to improve the volume and not losing later on, or some bone substitute with a very slow or no resorption rate. And in some cases, I may have or I may need new vital bone and volume on both sides. So what is the meaning of an augmentation like this? I took these pictures from the social media. But nowadays, with the information we know, this is a very questionable augmentation. Meaning that if I want to have the bone augmentation till this line, which is the line connecting the envelope, bony peak on one side to the other, yes, I'm basically killing an ant with a bazooka. I'm very effective, but it's very basic. If my goal is to reshape the crest like similar to a tooth, I'm choosing the wrong material. Because I need just to let the time run, and I'm going to have 60% resorption only in the first 8 months. And this is published since 97, so it's not something new. It's very old, we know this since the beginning. So remember this picture, because this is fundamental if you work, for example, with autogenous bone, that every time we are under muscle activity, and in the mouth we have a lot of muscle activity. What is stable is just if you're grafting inside. If you're grafting outside with resorbable material, you are going to lose it. It's just a question of time. It may take 8 months, may take 1 year, 2 years. Usually the longer is 3 years. Because after 3 years, we have renewed completely the bone structure in our body. So, stability inside, instability outside. So, we have to ask how I want to build up the bone in that area. How I want to proceed. I want to support the biological process because my goal is increase the bone where I'm going to place the implant, and then autogenous bone is the best material we can use to do this, or I want to create a volume, meaning that I want to do something that the body is not going to change as a shape. Then I have to look to soft tissue and I have to look to non-resolvable material. Because physiologically speaking, the body will not change that shape during the follow-up. And so we have really to ask ourselves, when I'm going to approach a case, what is the goal of my approach? I want to give back the shape, meaning that I have the bone here, and what I want is to build up something that was outside and now we are missing, so recreate that environment. And obviously, I must remember that this defect is not the sum of the bone. It's a combination of bone and soft tissue collapse. The bone is from 3 millimeters up, and the soft tissue is from 3 millimeters down. So I have to work on both sides, and my goal in a situation like this is to use a non-resolvable material because it's completely outside the anatomical contour. So I'm going to place my implant, I'm going to graft on the buccal shape with non-resolvable material, and I'm going to increase also the soft tissue. And this is the situation after months, 5 months, and now I have a nice shape from an axial point of view. I have a nice soft tissue, and that the prosthodontist will develop, and this is then the natural tooth on one side and the implant on the other side. And what I want to notice is there's many cases when we are working bone level and the prosthodontist must detach this abutment to change the shape, we may see some remodeling that is related to the fact that this area is not stable for the soft tissue. So even if you have a nice results in terms of clinical appearance, we still have a modeling of the changing of the shape close to the color of the implant when we are not taking about the intramucosal component. Now, on the opposite, if I'm working on vertical deficiency and you see on the bony peaks that I'm completely inside the bony contour, I can use autogenous bone as a lowly graft material, and I'm going to appreciate during the follow-up a lot of stability. This is 1 year, 3 years, 5 years, and this is the 10 years results compared to the starting point, meaning that we are going to reshape the crest exactly following the anatomy and not changing the anatomy. And this is going to happen also in the maxilla. Look, this combining defect with the sinus and vertical augmentation, this is the healing after 4 months, this is the situation after 5 years, and this is the situation with the CBCT after 10 years. But we can look to some cases even older, even with horizontal augmentation, with the puedes approach, 1 bone harvesting for 2 augmentation. This is after 4 months. This is the soft tissue at the end of the process. This is the overall case from the beginning to the end. And this is 12 years later from a clinical appearance. We are going to see how is the bone, and the most important picture is here in the middle. Because when you see that we follow it, the correct anatomy of the patient, everything is stable. And this is the clinical view after 15 years. And this is very nice because we can see this even with vertical bone augmentation. This is the case at the beginning. This is the bone after 4 months. This is the case pre and post, maintaining the teeth. This is again the initial and final situation, and this are the 7 years and the 15 years clinical appearance. So, radiological appearance. So very, very stable amount of bone regenerated. Now, what we want to have, obviously, or what we